If you or a loved one has ever been in the hospital, you've probably met a lot of different people involved in your care. From physicians and nurses to therapists and case managers, it truly takes a team. But for many patients, it can be difficult to know who is responsible for what. So, today on Healthy Conversations, we're talking with Dr. Deol about how the hospital care team works together and who's in charge of your care during a hospital stay. I'm joined today by Laren and Justin as we break down what patients and families can expect. Dr. Deol, thank you for being here today. We appreciate it. I know it's your day off, but we brought you in just kind of if you want to start telling us about your role as a hospitalist.
Well, absolutely. It's my pleasure to be here. I guess a little bit about myself. I am internal medicine trained. Finished my residency in 2016. Worked in Nashville for 5 years, which is where I was born, and then came down here about 4 years ago. And since then, I've been a hospitalist at Athens Limestone Hospital. And as of July of last year, medical director took over for Dr. Hansard, who had been there for, I want to say, close to a decade. So it's been a while that he's been here. And essentially, we have a hospitalist program at Athens Limestone. It is basically for full-time hospitalists. We have a couple that work PRN as well. But essentially, as a hospitalist, we are typically they're internal medicine trained, sometimes family medicine, and sometimes emergency or something like that too. But traditionally, it's mostly internal medicine trained physicians. And instead of kind of a split between primary care and inpatient care, we are fully focused on inpatient care. So we typically don't have a primary care practice when we work. We are in the hospital taking care of admitted patients, and then when you're discharged, we're no longer, involved with the care directly. Everything passes over to the primary care at that point.
Yeah, that's an important comment because I know a lot of patients will be, "Where's your office?" or "How do I
Yeah.
come to your
Yeah.
clinic?" or those kind of
A
things.
couple
And
of times a day, I get the
yeah,
kind of
I
questions.
know you do. I know you do,
Yeah.
which is good. That's flattery. They want to be able to come see you, but yes, it
Absolutely.
is a different.
I do always tell them, if I had a clinic, I would call you. You'd be my first patient. So,
Oh,
Oh,
that's
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 awesome.
great.
That's
That's
awesome.
great. So kind of what does a typical day look like for you in the hospital?
so we work. Hospitalists tend to work 12-hour shifts. That's pretty typical, across the country. And essentially, it's usually a 7 a.m. to 7 p.m. shift. So at 7 a.m., we come in. Generally, are going over our list of patients from the prior day and just kind of prioritizing who needs to be seen first, what orders need to be put in. We have nurse practitioners we work with as well, so we split the census up a little bit. So we run the entire list together. And then basically, usually we'll touch base with the case managers first thing in the morning as well, just to let them know these are the potential discharges. These are the patients that might need something, addressed, up front. If I'm expecting they might need to go to rehab or something like that, so they can get the ball rolling on that type of process. And then basically, we're just prioritizing patients based on who needs to be seen first. So at Athens, we have an open ICU. So the hospitalists manage the ICU patients as well. We do have a critical care doctor that assists, but you're not admitted to the critical care doctor, you're admitted to us. So often I'll go to the ICU first and see those patients because they're, most generally the sicker patients. And then we go to the floor and round on patients just based on kind of acuity and who needs to be seen first and things like that.
Yeah, because the critical care doctor has a clinic. He's not always in,
Right.
so for that
Yeah.
reason too.
Yeah,
Okay.
absolutely. And some places will have a closed ICU. They have 24/7 critical care coverage, but places that don't have that, they need someone who's there 24/7, and that's the hospitalist team. So,
That makes a lot of sense. So why has the hospitalist model become such an important part of, I guess, modern hospital care?
I would say, as time has gone on with all of medicine, I think there's every specialty has become more robust, and then you have more and more subspecialties because of the overall the advances in medicine, essentially. And hospitalist is kind of a similar thing. Traditionally, people would have a primary care clinic, and then when their patients get admitted to the hospital, they would see them there too. But it's becoming very demanding just to be a primary care physician and manage so many patients and these chronic diseases that people are living a lot longer with them. They need more robust management, a lot of coordination with different specialists. So primary care practice is a full-time job in and of itself. So it's difficult to balance that with patients in the hospital too. So I think that's the biggest reason, is that essentially the people in the hospital do need, it's kind of a separate branch of medicine, essentially, where Obviously, we all learn the same sort of treatments and everything, but the way you manage people outside the hospital versus inside the hospital is very different, and that's why hospitalists are just kind of focused and more trained and experienced with the inpatient management,
Yeah, and you have a quicker response time because 'cause you're always in the
where
hospital
someone
if
is
something
always
needs to
there.
be changed or
Mhm.
adjusted or something.
Absolutely, yeah, and that's key because a lot of these patients, obviously, we're treating them and things come up all the time, people's status changes and medications need to be put in or people need to be assessed very quickly to make decisions, and the hospitalist is in-house 24/7, so
And I might be kinda newer to this. Is hospitalists a newer trend that we're starting to see in hospitals? Is that something that's
20 years
yeah,
maybe?
yeah,
So, yeah, considering healthcare, that
yeah.
still is kind of a new
I
thing.
would say in the grand scheme of things, yes, but, like I said, I finished residency in 2016, and hospitalists were pretty well established at that point, so, there are still some people that do both. Some physicians do primary care, and they'll see their patients in the hospital, but like I said, the demands of that are growing
yeah,
essentially, so
gotcha.
Yeah.
Okay. So I think you kind of covered one of my questions, but when someone is admitted to the hospital, you are primarily the person managing their care, correct?
in most cases, yes. In general, when a patient gets admitted, the vast majority are getting admitted to the hospitalist service, and then if we need a different specialty, we consult them. Sometimes you'll be admitted, for example, if you're getting admitted for like a knee replacement, and that's been arranged as outpatient, your attending doctor that you're admitted to will be the orthopedic doctor,
Okay, that makes
and then
sense.
they'll consult us to manage the medical issues.
Gotcha.
And then occasionally, sometimes like the general surgeons will take their patients and they'll consult whatever they need as well. So
So, like, if you have knee surgery, the orthopedic surgeon's going to come and look at your knee, but say you have trouble with your anesthesia or something like that, you would come in and kind of assess that.
yeah, if there's any sort of, obviously some people post-operatively have, minor complications. We're managing those types of things. We're looking through all the medications, trying to just basically keep everything medically well managed, essentially.
Or those instances where it was intended to be an outpatient procedure, but for whatever reason, you need to stay 24 hours or you need to
That does
stay
happen.
longer.
Most of them are planned, though. Most of them, you'll come in and they'll say, "You're gonna have this surgery. You'll probably be in the hospital 1, 2, 3 days," and that's what the orthopedic doctor just kinda monitors you from their perspective. But they'll get the hospitalist team in, and we kinda look over all your home medications and all the blood tests and vitals, and we manage kinda medications while they're there, and then when the orthopedic doctor is ready for you to leave, we just say everything looks good medically, and he can take over from there, essentially, so
Awesome.
So, when you have like a knee surgery or something and you have daily meds, or and you have to stay 2 nights in the hospital. So you're in charge of making sure they get their daily meds, and you don't bring them with you or anything like that?
No, people should probably bring them just or a list. I mean,
Right.
that's always what I'd say is just if you keep it on your phone or just a paper list that says these are the medications I take and the doses, that's really convenient. We do confirm a lot of times with the pharmacy, the nurses will do that and just make a confirmation. But if you bring your entire, bag of meds and we can just look at it
And then check it
and
off.
yeah, exactly, just put it in the
But
system
it
like
goes
that.
through the hospital, not you don't, like, hand it out to them.
No, 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 yeah,
Okay.
yeah, yeah. Unless it's a medication we don't have, then
Gotcha.
yeah, if we have the supply, we give it from our own.
Gotcha. I mean, that's something to think about.
Well, and medications are definitely a tricky thing, and I know, like you said, confirming it because I know, I've heard of, issues before personally with family and friends and things like that where they may know what medicine they take,
Mm.
but if you misspell it or you mispronounce it the least little bit, you can go from a diabetic medication to a stroke medication or,
Yes, yeah.
and so if I checking that with the pharmacy and the pharmacist, "No, that's not what they were taking.
Mhm, yeah, yeah.
This
So
is
sad.
it."
And it is very common, unfortunately. I mean, I think that's one of the more important things that can be missed very easily, if we had a database that just kinda kept all that information, that'd be great, but everything's more fragmented a little bit, so I can't just look at a computer and see what you picked up from Walgreens,
Yeah.
a month ago. So a lot of that has to be we have to communicate, we have to call and kinda confirm things, but that's what
Well,
we do.
and with names from drugs to generic names, I know, like, I can pick up a medication for my mother, and they're like, "You're picking up the Leva something," and I'm like, "Ativan?" Because 'cause
Yeah.
I'm like, in my head, I know it is Ativan, but this label says I guess the generic name or
Lorazepam,
something.
yeah.
Yeah. Okay. See, I didn't even have the right drug.
Yeah.
So I can definitely see where medications has got to be just the hardest thing to manage.
Yeah, it's a very easy thing to kind of just little mistakes can happen here and there, and like you said, most people don't know the names of these. I can't pronounce some of them myself, so they're unfortunately needlessly long sometimes. And but the generic names we know just because it's easier. When I hear that generic name, I know what class of drug it is very easily. Whereas brand names, there can be multiple of that, so it's
Oh,
easier for us when we're trained in it.
yeah.
But everyone knows Ativan, so I also know that too. So
That makes sense. Well, she got something new recently, and when we got it, because she does, the pill counter and, all that kind of stuff, and we got it, and she asked me a question. I said, "Oh, it's pink. Like,
yeah,
it's
that
pink. So
that
you
we
know the
don't know.
difference.
Yeah,
That's pink,
that I cannot tell you. I do not know the colors of the pills or the shape or anything. They'll say it has this certain writing on it. I have
I
no
can't help
idea.
you
So
there.
we Google it, and that's how we figure that stuff out. But
Yeah. But, I mean, I know they change medication colors and shapes and things like that to make it a lot easier, but, yeah,
yeah,
even for her, like I said, it was this new medication. "Oh, your new medication is pink."
yeah.
So.
And
That's how
most
you
of the
remember it.
yeah, most of the time we can have a conversation with them and figure out what they're trying to say. Obviously, they're mispronouncing it, but we can
Uh-huh.
usually figure it out. But a lot of times people they're on a number of meds and they can't remember exactly why they take each one of them. So we have to be pretty careful about that stuff. So.
Important reason to have a list.
Yes,
Yes.
absolutely.
We
Yeah.
have an active list.
Yes, definitely.
So when they've spent their time with you and it's time to leave, how do you talk to their primary care physician? Do you kind of reach out to them, follow up, how does that work?
The standard thing that we do with every patient is when you're in the hospital, you're being seen, you get a history and physical on the first day, and then we do progress notes every other day. When you're ready for discharge, we do what's called a discharge summary. And that basically lists every diagnosis and the recommendations when you go home, and then a kind of a good sort of synopsis of what happened in the hospital, what tests were done, what procedures, what the outcomes were, and then kind of our follow-up recommendations. It also has your whole medication list there too. And it
Good
will
to know.
say, these are the new meds, these are the old meds you're supposed to continue, these are the ones to discontinue. And that standard is to be faxed to every primary care doctor at the time of discharge.
Okay.
So that's the one thing that every patient definitely gets is a direct communication from us with that discharge summary gets faxed directly to the primary care doctor, and then when they see him in the clinic, they know exactly what happened in the hospital.
But it's good for you to keep up with it, maybe take it to your next appointment too, so they know,
Yeah, you
you
could do
know.
that. Yeah, and definitely, I think that's a good idea to have those type of files with you for sure. But we fax those to the primary care, and sometimes we'll fax them to other physicians as well. So if we think the neurologist needs to know all this too, I'll let the nurse know, fax it to their neurologist as well. Sometimes we will contact primary care doctors during the admission because we're not able to get an accurate history sometimes, or we're wondering what might have happened on previous visits to see if maybe they were already tracking something and may have already started some medications and the patient, didn't update their medication list or something like that. So sometimes we'll get them, just involved early and just get some more information.
So say you come in with having a heart attack and you've never had a cardiologist, will you send that to a new cardiologist for them? Or do they have to kind of pick one? How does that work? You've
So,
never had that kind of doctor
right.
before.
Yeah. Yeah. So, well, definitely, if that were to happen, you would have the cardiologist be seeing you in the hospital. And then that cardiologist, if you wanted to continue and follow with them, they would give you follow up information. A lot of
Gotcha.
times, their office will just call and make an appointment before you even leave the hospital sometimes, just to make sure that's in place before you go. And you can obviously decide if you want to see another cardiologist. And our recommendations in the paperwork would say, cardiology recommended follow up in 2 weeks. Doesn't mean that cardiologist necessarily, but that would be the most seamless way because
Gotcha.
they saw you in the hospital, they know what happened, and they can carry on when you leave. So
That makes sense.
Mhm.
And that touched on one of the questions I have. Patients come in and they see so many different healthcare professionals when they do the hospital stays. Can you kind of help explain the different roles of nurses or specialists or anyone they may see in the hospital?
yeah, absolutely. I can say being on the other side of it, my daughter was admitted to Huntsville Hospital for a couple of days, and even I, having been in I was like, "Who's coming? I don't know who you are,"
Exactly.
and I couldn't remember any names. And it's very understandable in that situation. You're not your best. You're sick. You're not thinking about the things that you normally do. You're not as aware, and names are always hard to remember. And there's so many people coming and going. I
You think
mean,
everybody's a nurse that's
yeah,
coming in.
Exactly.
Everybody's a
I know.
nurse.
Yeah, the only reason they say I'm not is because I'm wearing a stethoscope.
Right.
There you go. There you go.
But everyone else is a nurse. Yeah. But yeah, there's definitely a lot of important people that you should kind of be aware of, and it'd be good to kind of. What I always say is just kind of take a little notepad. They give it to you in the hospital too if you ask for it. But whenever someone comes in, just write down, this is my nurse, this was my respiratory therapist, that type of thing. And if you can keep that sort of list, that kind of jogs your memory when people come in too. But to answer your question, I would say, I mean, the most important person you should know is your nurse. They're going to be seeing you more than anyone else throughout the day. If anything were to change, they're more than likely going to be the first one to notice it, and then they're going to be the one relaying the message to whoever needs to know about it. If you have any concerns, you hit the button, and the nurse is the one that comes in and talks to you about it, and then they decide if that's something they can manage with what's already ordered, or is that something they have to contact the physician. So the nurse is definitely the single most important person while you're in the hospital, just from a care perspective. As far as physicians, like I said, you'll be admitted to one service. So most of the time it'd be the hospitalist. And I usually tell people when I come in, I'm the hospitalist, you're admitted to my service. Any other doctor that comes in is a consultant. So for example, if you have a really bad infection, we'll consult infectious disease. They'll come in, introduce themselves. So you'll have two separate doctors on the case. And it'd be good to kind of know what each doctor's role is, because a lot of times we'll get questions that aren't for us essentially, and we can still sometimes answer them, but a lot of times, they'll ask me, what's the orthopedic surgery going to be like? And I can't answer that. So, and I usually tell them I'm obviously not trying to tell them not to ask questions, but I'm not the one doing the surgery. I don't want to be the one to tell you what's going to happen and not really have a good, understanding of it as much as the orthopedic doctor. So it's good to kind of, know who's doing what
Yeah,
essentially.
makes sense.
And then we do have more what they call ancillary staff, but equally as important, we have
Yes.
respiratory therapists. So a lot of people that come in with breathing issues, COPD problems, things like that. We'll put the orders in, but the respiratory therapist is administering all of it. They're specialty trained in that, so a lot of times they will give us recommendations just based on what they're seeing. So they'll say, I think this nebulizer is not going to work as well. Maybe we can add this, or do they need something like a flutter valve to produce more, mucus to clear out their lungs? They're specialists in that, so they are very attuned to respiratory problems. So very important for anything, in that case when you come in with that type of disease, essentially. And then, physical therapists are one too. A lot of our patients, in general, the patient population is skewing towards, 60s, 70s, 80s. And when you come in that sick, you're not getting around as much. The weakness does tend to progress a little bit. So we like to get physical therapy involved relatively early. Obviously, when you're stable enough to get up and move. But they'll come in. It's pretty easy to tell when it's a physical therapist if they come in with a walker. But
There you go. Yeah.
but yeah, they'll explain what they do and basically get you up and do a full assessment, and then they relay that information to us, and we can kind of see how you progress, and then that kind of also dictates, where you're going to be going from here. Because obviously, if they think you're too weak to go home, then that's the conversation we have to start having about what the next step is when you're ready to go. So
Mhm.
Absolutely. So clearly a lot of team members.
a lot,
Yeah,
yeah,
and I know at the hospital, we kinda color code a lot of people too, so
yeah,
hopefully, if you're not seeing their badges, you're noticing
the colors,
the
yeah.
nurses are in navy and
Respiratory's in black, I
black
think.
yeah.
Yeah.
Okay.
I was sitting here in my head going, "What's respiratory in?" And then,
Isn't
your
babies pink? Is that what
the who?
the babies aren't they pink, or is it gonna be
No. Lord, I can't remember right this minute. I can't remember, but I know like the environmental service staff, I believe, is in purple,
Yes, yeah.
and food service is in red, and so we try to kind of, and imaging, I think, is in kind of a lighter blue color
Yes,
stuff.
yeah,
So
and surgical type stuff is in that green.
yeah,
So,
Gotcha.
yeah, the ones that even, like, transport to, surgery and stuff like that, so,
yeah.
yeah.
So we do try to color code so you kind of know.
And if you think about it, just naming all of those different different people, in any given day, you could have, 12, 13 different people walking in and out of your room, so
Yeah, we haven't even said anything about the nursing assistants.
yeah,
I
and
mean, they're
techs and things like
yeah,
that,
the
yeah.
techs, they're
Mhm,
they're all over doing a
mhm.
lot of work.
Yeah,
So
yeah.
yeah.
And how do they all coordinate on a single patient care?
It's a lot of it is basically communication. Most of it with the nurse. That's why I said they're kind of the single most important, because they're the point person on the floor. And you'll have a charge nurse as well. So that charge nurse, he or she is going to be kind of monitoring everyone on the floor. They don't have their own specific patients, but they're the ones that sometimes we'll call them directly because they're the ones sitting at the front desk and say, these are the orders that need to go in, and they relay that to the nurse. But yeah, it's basically a lot of communication. So when physical therapy comes and works with you, they will leave a note. But if they think it's something that needs to be addressed, they'll talk to either me or they'll talk to the nurse or possibly the case manager, and we all kind of communicate amongst each other. So the key is really communication, and that's something we work on every day.
Yeah, we missed saying something about the case managers, but outside of your nurse, the case managers are kind of there, like, coordinating discharge or
Yeah, yeah, it's pretty
something?
much coordinating sort of the I guess the non-clinical plan of
Right,
care. So I'm doing more of the clinical along with the
right.
nurse and all that, but they're the ones that are, from early on in the admission trying to figure out what your needs might be. Because essentially when we get you ready medically for discharge, we want to already have that sort
In
of in
plan,
place. And
yeah,
yeah.
Gotcha.
makes
Mhm.
sense.
Yeah.
And so, obviously, you already talked about the communication, kind of, how important that is. Um, so and of course, I kinda jumped ahead all the way down to talking about some discharge stuff. Um, but who should patients or family members, like, who should they talk to if they have issues?
Yeah, really, there's a few different people. It just kind of depends, but the initial go-to is generally the nurse. Like I said, they're there, laying eyes on the patient multiple times a day. They're spending the most time with them, so they do know the patients the best from that perspective. But if you have any sort of general medical question, or even just any question at all, if you need me, I can always be there and talk. Sometimes if the families aren't there, I'll call them on the phone or something like that. If it's more specifically like, which rehab, do we want the patient to go to, or what are their options for kind of discharge stuff? The case manager is the one that kind of really handles all of that stuff. But those questions, any of us can sort of field them and then relay them to the right
Yeah.
person. So
Well, and then we also have patient advocate,
yes, yeah,
that comes through and visits every patient also.
yeah, absolutely,
Um,
yeah,
so
yeah.
when you start
It's a
naming
lot.
It's a
people
lot more than
off,
you
It's
think.
a
It's a
lot
it's a
more
lot
than you
more
lot,
than
think.
you
Yeah,
which
think.
even I kind of
yeah,
I'm like, there's actually quite a few more than I thought. So
feels a little overwhelming when you kinda start putting it all
Mhm.
together.
yeah, absolutely. And that's why I don't really, begrudge any patient that can't remember who came in and what they said and all
Yeah.
that. It's a tough situation, even if you're fully healthy. So I don't expect them to be fully aware of everything that's going on all the time. So
What's kind of the rule out of every 10 things you tell them in the hospital, they'll remember 2, something
yes,
Oh,
like
wow.
that?
yeah, and that's probably
Yeah.
true. And I do
Yeah.
repeat myself a lot during, my communication with them in the room because I usually will tell them everything up front. It's a lot for them to deal with, and they're non-medical, so you know they're trying to process all of this. So I usually do kind of a summary at the end and say, "This is what we talked about. This is the plan. Do you have any questions?" And a lot of times that helps kind of reframe things, but sometimes it's still things that get missed for sure.
Absolutely. One thing I recognized when my grandfather was in the hospital, they had a dry erase board in the hospital
Yeah.
room where they write
Very good,
notes
yeah.
down and they do things, and it's not they're leaving notes for the patient, but also for the person coming in next after them. It's
Yeah, yeah,
pretty
and
cool.
that one of the things they do is definitely they put who's your physician, who
Yes.
is your nurse, these kind of things on the board so that that's all just right there in their view and they can look up and say, yeah, that's who told me this. But they also, I've seen they put what's our goals for today, and that's a really good way because the patient, that's what they're really concerned with is kind of what am I getting better? What's the kind of metric we're looking at to say I am getting better? Sometimes the goal is just to get up and walk today. Sometimes it's we're going to try to eat a little more today. Sometimes, it's just, have a
Sitting in
good
a
day. Yeah,
chair,
just yeah, getting
yeah.
up, have a good day today, basically,
Yeah.
so, yeah.
Yeah. Well, that's
So, when you see your patients, what is one thing you wish they would do to help you help them? Like, we talked about a medication list. Is there anything else that like you just kind of need to have maybe on your person or know that makes your job easier?
Medications for sure would be one. A lot of times families help with that though. They a lot of times they'll go home and get all the medications or call them in or something like that. I would say the single thing that a lot of patients seem to struggle with is they have a lot of questions but they don't write them down. And then in the moment,
yep.
even if it's only 3 or 4 questions, you ask the first one and I'm giving an answer, and I can tell they're trying to remember the rest of them while I'm talking. So I try to make it brief. They might remember the next one, but then after that, they lose track of it. So I would say definitely writing those things down as you think of them during the day, because I'm going to come in once, maybe twice a day, just to check in on you. But if you write them all down as you think of them, then if I come in the next morning, you'll have a list of questions and I can address all of them very
So
easily.
if you're staying in the hospital, take a notebook.
Yeah, and they provide them
Well,
there.
yeah,
Okay,
so,
I was
nice,
just gonna
nice.
say, you do kind of have like an admission book, I guess,
Yeah.
that has a lot of information in it, a lot of information, and a lot of it are things that by rules and regulations we're required to have in there, your privacy practices and things like that. But, it has in it the TV remote and it has in, the channel numbers, and then it
Yeah.
has in there the numbers for like the patient advocate or if you need to speak with somebody in medical records and some things like that. But then it has also areas for you to be able to keep notes and kind of keep it all in one place.
Yeah, and the
So,
nurses can provide just a separate notepad too if you ask for it, and it's just a lot of people don't think about it while they're in the hospital because they're sick and they
yeah.
just wanna get better, so
Well, and I can tell you, I mean, I hate it even myself if I'm going to a doctor's appointment and then I walk out and I get out in the car and, 30 minutes later, I'm like,
I should have asked that.
"Dadgum," 'cause, a lot of times you are only seeing them once a year,
Yeah,
maybe
I
twice a
know.
year, and
Yeah,
you you've thought for a week, "I have this appointment, I'm gonna ask this question," and then you forget.
and I would honestly say the sticky notes on your phone is a good way to do it. A lot of people don't
Yeah.
utilize that in the hospital, but that's an easy way because you have your phone right next to you. You can just jot some notes down and,
That makes sense.
Yeah, it does record some things. Um, well, like I said, the hospitals program in general is still kind of relatively new. Like we were saying, there's just so many changes in healthcare, but I believe that patients get great care with being able to have that response, having that person in there and having that response. And I know for the staff, that makes that opportunity for them to be able to respond to needs as they're changing versus having to kind of wait and
yeah,
catch the doctors when they
yeah,
come in
absolutely.
on rounds. And in the traditional way, if you think about it, a lot of times the nurse that was with the patient during the day is not the same person who's there by the time a clinic physician makes their rounds.
That could be
Yeah.
the case, yeah,
So,
yeah, and they do work kinda similar. They're the same 12-hour shifts as us, but yeah, it's sometimes you're not quite sure if that's gonna happen, so,
yeah.
yeah.
So what kind of let's talk about discharge. What kind of determines when a patient is ready to go home or kind of what kind of happens at that point?
Yeah, from my perspective, it's, when you come in, you have a certain diagnosis and we're basically medically treating you and we're looking for certain metrics to say that you've improved enough to where you don't require the hospital anymore. A lot of this can either be managed at home or, with your primary care and stuff like that. So that's a lot of what we push for. Obviously, uh, if we had, perfect resources and all that, we'd keep you till you were 100% healthy and then you just walk out the door and there's no more treatment. But a lot of this, like I said, we can convert IV antibiotics to oral antibiotics and things like that. So those are the things we kind of look for as certain metrics that we're saying, medically speaking, you're getting to that point where now we don't need to keep you here anymore. You can manage this outside of the hospital. And then the other key to that is, are you able to go home? So that's why I was talking about physical therapy, case management gets involved. A lot of our patients do require some type of short-term placement like rehab or something like that. So if we get that involved early enough, obviously we have to submit things for insurance authorization and then we have to get a bed at the rehab. So if we wait till that day that you're ready to be medically ready, we're waiting a few more days just to get all the stuff set up. So that increases your length of stay for no good reason, essentially. So we want to try to, once you're ready medically to go, we want to kind of get you transitioning to the next point because otherwise you're just kind of in a holding pattern.
Yeah.
And if you do need rehab, then staying at the hospital means you're just not getting the treatment you need because you'd be much better off going to the rehab facility and really starting that more intensive therapy to get back on your feet quicker.
Yeah, I've heard people say that discharge plan kind of starts upon admission. So they're kind of running parallel, even if you're not seeing or hearing much about it at
Right.
the time. It's
Yeah.
kind of already kind of in progress, I guess you would say.
Yeah. A lot of it's happening behind the scenes.
Right.
But once you do need to know what's going on, that's when case management really starts interacting more with the patients and families and figuring that stuff out. So.
And patients like to kind of have that idea because I think we all, when we reach a certain point, we're ready to be in our own bed or our
Yeah.
own
Oh, yeah.
chair,
Mhm.
our own shower, all of those kind of things that do help with the healing process to get back to our own stuff,
Absolutely.
our pets, all those things.
For some patients, that starts even the moment they arrive to the
Oh,
ER.
Yeah.
100%. 100.
Some people are
Yeah.
very eager to get out, so
Yeah, I don't disagree. I
Yeah.
don't know many people who really want to be.
yeah, there's not
Healthcare
many.
is definitely not one of those things that people are like, I want to be in the hospital for 3 weeks or 2 days,
Yeah,
but
yeah.
it is a necessary
Yeah.
part of it.
And there are a lot of things that we can do outside of the hospital. Like I said, oral antibiotics, even IV antibiotics. If someone needs like long term for weeks of IV antibiotics, we can set it up that they can do it at home, or they can come in. Sometimes they have newer antibiotics that are just once a week dosing. So you can come in, get an IV, get your antibiotics, go home, and just do that once a week for a few weeks. Oral steroids, any other sort of meds that we can sort of convert to oral medications. A lot of that, as long as you're stable from everyone's perspective. We don't have to monitor you in the hospital anymore. You're going to recover better at home than you would in the hospital for sure. So we try
Yeah.
to
Absolutely.
do that as soon as we can.
Yeah, my husband had to do IV antibiotics for a period of time, and, I mean, he was still going to work, and he'd take time off and go do his IV antibiotics and come back, and so
Yeah.
we definitely
You feel better too, getting
Yeah.
back to feeling like a normal person. So,
Exactly. Yeah.
Yeah. Modern healthcare.
Yeah.
Modern healthcare. So one kind of last question. So how does the hospital team help ensure a smooth transition back to home? Like, what is that follow up? I know you kind of said earlier, that y'all can kind of put on the notes, follow up with cardiology or whatever. But what does that kind of last piece look like as people leave the hospital?
Yeah, a lot of it's communication with the patients, making sure they understand because there's going to be new medications a lot. Some people, like for example, a new diabetic comes in, so we get our diabetes educator teaching them about diet. The nurse is teaching them about insulin administration, for example, or something like that. So we just make sure that they can demonstrate that they understand kind of what they need to do to manage this outside of the hospital because they're taking their care into their own hands at that point. Follow-up appointments, we make some of them that are very important. Some of them, we just give them the information. Sometimes if it's a weekend, you can't make an appointment, so that's what happens with that. And then case management's working on kind of their needs at home. So maybe you need a rolling walker, maybe you need a bedside commode, maybe you need oxygen just temporarily. Those things all just kind of getting done by the case manager and all the different pieces coming together where if we feel very comfortable that the care can transition to home and you'll get exactly what you need essentially.
Yeah.
Wow.
Okay. Y'all have any other questions?
No, I think you did a great job answering those right there. That was
Oh,
perfect.
awesome.
I'm still in my head kind of going, oh, yeah, I forgot about this person and that person. And there is a lot
A
to
lot of
do.
people. Yeah,
There's
yeah.
a lot of components of healthcare.
The hospital is kind of like a small town, I
It
guess.
is.
So
It really
yeah,
is.
it's just a
Yeah.
bunch of
Mhm.
people doing their respective thing to keep everything running. So
Yeah, it really is. Okay. Well, thank you so much.
absolutely.
thank
It's
you.
no problem. It's my pleasure.
We want to say thank you to Dr. Deol for helping us better understand how the hospital care team works together and what patients can expect during a hospital stay. Knowing who's involved in your care can make the hospital experience much less overwhelming. We hope you'll tune in again for another healthy conversation that makes a difference.